Speaker is Dr. Asmaa Youssef, lecturer of Radiology, Benha University. We would be delighted to ask her to speak about musculoskeletal do not touch lesions. تفضلي.
Assalamu alaikum. First of all, Hisham Sheikh, our dear professor. I am Dr. Asmaa Youssef, lecturer of Radiology, Benha University. My lecture is about an important topic, which is don't touch lesions in musculoskeletal imaging. Leave-alone lesions, skeletal leave-alone lesions, or also called don't-touch lesions, are so characteristic radiographically that further diagnostic tests, such as biopsy, are unnecessary and can be frankly misleading and lead to additional unnecessary surgery. Thus, a radiologic diagnosis should be made without a list of differential possibilities. In some cases, a diagnostic error can have a catastrophic result. For example, biopsy performed in patients with myositis ossificans can lead to incorrect diagnosis of sarcomatous lesion and consequently to mutilating surgical procedure. These lesions can be divided into three main categories: normal anatomical variant, post-traumatic lesions, and lesions that are real but obviously benign. First category is normal anatomical variant, like pseudocyst of the humerus, dorsal defect of the patella, os odontoideum, and the bipartite patella. Pseudocyst of the humerus is merely an anatomical variant caused by increased cancellous bone in major tuberosity of the humerus that gives the region a more lucent appearance on radiograph. With hyperemia and disuse caused by rotator cuff problem or any other shoulder abnormality, this area of lucency may appear strikingly more lucent and mimic a lytic lesion. As we see here, in this patient after an bicycle accident, this image is suggestive of a humeral cyst on X-ray, an incidental finding that wasn't confirmed in the complementary view or on the MRI study. As we see here, there is nothing indicating that it was a humeral pseudocyst. Second is the dorsal defect of the patella. Dorsal defect of the patella are benign subchondral lesions of unknown etiology, which may be mistaken for pathological bruises such as a focus of infection or osteochondritis dissecans. This condition is often asymptomatic and incidental finding on knee imaging. On plain radiograph, a rounded focus of lucency, as we see here, surrounded by sclerotic margin in the superior lateral characteristic location, superior lateral quadrant of the patella. On MRI, low signal on T1, high signal on T2 weighted image. Notably, the lesion has a sclerotic rim and usually not associated with marrow edema. The overlying cartilage is usually but not always intact. As we see here, there is subchondral bone plate irregularity with intact overlying cartilage as the superior lateral aspect of the patella, which is consistent with the diagnosis of dorsal defect of the patella. Third is os odontoideum, which is congenital unfused ossification center above augmented lens, may be asymptomatic or lead to atlantoaxial instability. On imaging, there is rounded or oval, well-corticated ossicle that lies above and separated from the body of C2 by a lucent gap, which is wider than a fracture, usually located in the position of normal odontoid bruises. On this plain radiograph, lateral radiograph, we show the unfused ossification center superior to the body of C2. Sagittal CT of another patient shows unfused ossification center superior and posterior to the body of C2. The smaller ossification more anteriorly is the anterior arch of C1. Bipartite patella unfused accessory ossification center as the superior lateral aspect of the patella affect about 2% of individuals. Note an important thing here to know that the superior lateral location of this bony fragment, as we see here, and there is in relation to the patella with a smooth margin, usually widely separated, and there is some sort of sclerosis with no overlying soft tissue swelling, not to confuse with any patellar fracture. A second partition in our literature is post-traumatic lesions, which are like myositis ossificans, avulsion injury, cortical desmoid, use, fracture, and pseudodislocation of the humerus. Myositis ossificans is an example of lesion in which biopsy shouldn't be performed because its aggressive histologic appearance can mimic a sarcoma. The typical radiologic appearance of myositis ossificans is circumferential calcification with a lucent center. This is often best appreciated on CT examination. A malignant tumor that mimic myositis ossificans will have a ill-defined periphery and a calcific or ossific center. So biopsy, as we said, should be avoided, and MRI is misleading because peripheral calcification may not be conspicuous and often there is marked soft tissue edema surrounding it. This plain film of the femur in patient show a calcific density adjacent to the posterior cortex of the femur. It is calcified primarily in its periphery. CT was also obtained and showed that the calcification is unequivocally peripherally, and this is visually diagnostic of myositis ossificans. This is a case of another young male with left shoulder pain after trauma. There's left, on MRI, there's left tumor-like lesion in the left axillary region involving neural vessel and bundles. On ultrasound, there is peripheral calcification and no color flow on Doppler mapping, and on CT and PET scan, there is increased glycolytic activity, and there is also diffuse circumferential peripheral calcification, which is pathognomonic for this lesion, which is myositis ossificans. Avulsion injury, another post-traumatic injury in which a biopsy can be also misleading. These injuries have an aggressive radiographic appearance, but because of the characteristic location at insertion site, lies the anterior inferior iliac spine or ischial tuberosity should not be recognized as benign. So we said again, biopsy can be very misleading and again can give us a mistaken diagnosis of sarcoma and should therefore be avoided. In this picture, in this brain radiograph, cortical irregularity is seen here as ischial tuberosity. In patient with pain over this region, raises the question of a possible tumor. This is a classic appearance, however, for an avulsion injury, and a biopsy should be avoided. Cortical desmoid is a benign lesion considered by many to be an avulsion of the medial supracondylar region of the distal femur. It occasionally simulates an aggressive lesion radiographically, and on biopsy can also look malignant. Here we see focal cortical irregularity in the posterior aspect of the femur with adjacent subtle periostitis, but the location and the characteristics of this characteristic location and appearance are characteristic of cortical desmoid, and the biopsy shouldn't be performed. This also an AB film of knee in a child show a faint lytic lesion in the medial aspect of the distal femur. Axial T1 weighted image and T2 weighted image show MRI shows that the lesion show a cortically based lesion here in the medial supracondylar ridge, which is characteristic of cortical desmoid. GUS trauma can lead to large cystic GUS or subchondral cystis near joint that can be mistaken for other little lesion, and thus biopsy may be performed. Although biopsy specimen is not likely to mimic a malignant process, it should be also avoidable because GUS from degenerative disease almost always are associated with additional findings, such as joint space narrowing, sclerosis, osteophytes, and diagnosis should made be radiographically. As we see here, this plain film of the hip in patient with hip pain show in the supraacetabular region a lytic lesion, which has a benign appearance, and there's also mild osteoarthritic changes as sclerosis and joint space narrowing. Hence, this was believed to be a subchondral system. But several years later, the same hip show a large lytic lesion that still appear benign. The osteoarthritis has increased in severity, but because of the growth of the lesion, a biopsy was performed and it was found to be GUS. A biopsy should have been avoided. Fracture, occasionally a fracture will be the cause of extensive osteosclerosis and periostitis, which can mimic a primary bone tumor. Biopsy result in such a case might resemble those of a malignant lesion. Therefore, any case associated with trauma should be carefully reviewed for a fracture. In this case, this young male experienced pain around the knee for 2 weeks and showed diffuse sclerosis and extensive periostitis around the distal femur, which was believed to be characteristic of an osteogenic sarcoma. But the periosteal reaction was believed to be much thick and dense to present a malignant type of periostitis. A small offset here, we can see it as epiphyses, indicate epiphyseal slippage consistent with Salter-Harris epiphyseal fracture. The patient had fallen off his bicycle and fractured his femur, yet he continued to be active, so a lack of immobility caused this exuberant callus was misinterpreted as aggressive periostitis with a large amount of reactive sclerosis, all of which mimicked an osteogenic sarcoma. The dislocation of the humerus results from occult fracture with distension of the glenohumeral joint due to hemarthrosis that causes inferior displacement of the humeral head. This may be mistaken for shoulder joint dislocation. Often attempts are made to relocate the humeral head, but it is both fruitless and painful. As we see here, there is occult fracture of the humerus, and there is on AB view, the head of the humerus is inferiorly subluxed and mimics a posterior dislocation. On a transscapular view, there is the show that is not anteriorly or posteriorly displaced, and there is no glenohumeral dislocation. Second category in our lecture that is true lesions that are obviously benign, like non-ossifying fibroma, bone island, costochondritis, simple bone cyst, bone infarction, fibrous dysplasia, synovial cystis, melanostosis, vertebral hemangioma, and discogenic vertebral sclerosis. Non-ossifying fibroma are quite common fibrous lesions of the bone, predominantly in young. They are radiolucent lesions with sclerotic border, typically eccentric in location. This lesion demonstrates several classic features of non-ossifying fibroma, as it is tibial proximal metaphyseal lesion, eccentric location with thin cortic scalloped and sclerotic margin, slightly expansile. This lesion, cortically based lytic lesion, show sclerosis, indicating healing and involution. Bone island, small bone island in stools are common incidental finding on imaging examination that are seen in various body sizes, most often in the pelvis, femur, or axial skeletons. There are sclerotic foci extending to the bone trabeculae, as we see here. There is a small bone island as a transition between the body and wing in right iliac bone. It is always asymptomatic. There is a question here, can it be a metastatic disease, especially when as large as the one we just looked at? There's two distinguishable characteristics. First of all, oblong in shape with long axis in the long axis of stress. Margins show bone trabeculae extending from the lesion into a normal bone in a speculative pattern. Here, we can focus on the speculative pattern of the bone trabeculae extending from the bone island. A related condition is osteoporosis, in which small bone island widespread in groups around several joints. Costochondritis, this syndrome is an inflammatory condition that presents as chondral hypertrophy of the costochondral interface and is often painful, often affect the single intercostal space. On MRI, this middle-aged female with chest wall pain, the MRI shows edema and the enhancement of the periarticular bone in the first left costochondral junction, extending to the soft tissue, adjacent soft tissue, suggesting local inflammatory changes. Costochondritis, no signs of associated fracture or collection. Simple bone cysts are typically occur prior to the third decade of life and are intramedullary lytic lesions with a sclerotic margin. If associated with fracture, a typical finding of a signal from a dislodged fragment. Here in this young old male, came with right shoulder pain and no history of trauma. Radiograph of the shoulder show a lytic lucent well circumscribed lesion as the proximal metaphyseal metaphysis of the right humerus, with thinning of the cortex and associated pathologic transverse fracture without aggressive features. This radiographic appearance suggests a simple bone cyst. Bone infarction, early finding on conventional X-ray can range from lytic to foci of bone sclerosis. On MRI, there is in the most acute phase, there is circumscribed lesions with bone edema showing serpiginous or geographic borders with low signal intensity. As we see here, in early bone infarct, mixed lytic and sclerotic pattern can resemble permeative bruises, but MRI can be helpful to avoid biopsy due to the characteristic location show serpiginous or geographic borders with low signal intensity. Fibrous dysplasia is the change in bone development and characterized by fibrous matrix and bone tissue. On examination, their characteristic ground glass appearance. This female came complaining of disproportionality between both sides of the body with an incidental finding of fibrous dysplasia on CT. Note this area of ground glass attenuation. Synovial herniation pits or synovial cyst is one of is present as radiolucent foci in the anterior superior portion of the femoral neck and thought to be a consequence of herniation of the synovium into cortical defects and might be related to femoroacetabular impingement. Melanostosis is an uncommon form of mesenchymal dysplasia. It manifests as a sclerotic bone with appearance of melted candle wax. We show here we can see textural alteration with linear bone sclerosis in the distal and posterior contour of the right femur. Vertebral hemangioma is the most common benign vertebral neoplasm. On X-ray, there is this classic appearance of thickened trabeculae with a vertical orientation. Last entity is discogenic vertebral sclerosis, is an entity that often confused with metastatic disease of the spine. It can mimic metastatic disease radiographically and clinically, and unless the radiologist is familiar with this process, it can lead to an unnecessary biopsy. It typically presents as sclerotic focal lesions adjacent to vertebral plateau, with narrowing of the underlying disc space, occasionally accompanied by osteophyte formation. It represents just a variant of a small node and shouldn't be confused with metastatic disease. As we see here, these films all show sclerosis on the inferior portion of the L4 vertebral body with associated minimal osteophytes and adjacent disc space narrowing. This as a classic appearance for discogenic vertebral sclerosis, and the biopsy to rule out metastatic disease shouldn't be performed. Take-home message is essential that the radiologist knows the differential diagnosis of lesions that mimic bone tumors with aggressive malignant potential in order to avoid performing unnecessary invasive procedures and placing a heavy psychological load on the patient. I hope this small illustrative review will help our colleagues increase their accuracy in diagnosing these conditions, in which the radiologist play a fundamental role in avoiding serious diagnostic errors caused by unnecessary biopsies, as well as the catastrophic consequences of such errors. Thank you.